Hi everybody, I'm Stacy. I'm a registered nurse. Welcome to my channel. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's talk about, from the standpoint of being a hospice nurse, what are the signs of imminent death or that a person is actively dying. I've talked about this in videos before, and people said, why do you use the term actively dying? And the reason that we call it actively dying is because a person is imminent or in the last phases of life, and they are in the process of dying actively and could die at any time once that process begins. So when you come on hospice, you probably have questions. And if you're not a nurse that works with hospice, you may not be as familiar with the terminology that we use in hospice. So if you have any questions about that, I'd be so happy to answer some more, especially this one about actively dying, since it stood out to me. If you like what you see here, then I ask that you like, subscribe, and follow for more. So when someone comes on hospice, they have to have a disease process that would determine if it runs its natural course, they would have 6 months or less to live. So that doesn't mean a person's going to die in 6 months or less. Sometimes people live on for 1 to 2 years after their diagnosis. Some people are right within the window of that 6-month time frame. Some people die within days of coming on hospice. And the goal for us in hospice is to make sure that that dying process is comfortable and dignified, and at that person's desire for their dying process in terms of allowing their disease process to happen naturally. Now, I do not work in a state where they do assisted suicide. That's a terrible word for me to say, because I don't even know if I can say that word on a video. However, I do not work in a state that does that, and I simply believe in managing symptoms and allowing the disease to run its natural course. So what hospice is not us giving medications until a person dies by medication. We do not do that. So I just want to clarify that when a person is having the death that they would like to have, what I'm talking about when I say it from my standpoint is that a person is allowing their disease course to run its natural progression, and they are not seeking aggressive treatment, as in they're not going to the hospital and going into the ICU, they're not going to be intubated, they're not going to be getting CPR. Now, on hospice, we do treat infections with antibiotics, like oral antibiotics, and some hospice companies have an inpatient unit where we can administer IV medications for comfort, and sometimes that includes fluids or IV antibiotics if it's around comfort and end of life. And different hospice programs have different goals for end of life. I digress. That's for another video, which I would love to talk about, because I think that that's really important to understand. What I would like to talk about are the phases of death and dying. So typically a person who is going to be transitioning into death is like in a pre-transitional phase. Maybe they are not as alert as they were. Maybe they're sleeping more, they're eating less. You're just noticing that they're not interacting the way that they were. These are little clues that death is going to be coming soon. When a person stops eating and stops drinking, the body is doing this on its own. The person is not hungry, they're not thirsty, they don't have that need for those calories or those fluids as things are shutting down. And I don't ever mean to seem callous, and I also want to just make a disclaimer that what I'm saying on my videos is never, you should always take what resonates with you and leave what doesn't, and understand that I am not a doctor, and nothing that I say replaces medical advice or the advice of a doctor. I am simply sharing my experience as a nurse in hospice and the things that I've experienced and understood in hospice. So when a person is pre-transitional, those phases before they go into the active phase of dying, that is when they will be less alert, less talkative. You'll notice maybe they're sleeping more, they're not eating as much, they're not drinking as much, they're not having as much urinary and fecal output. You know, you're noticing that these things are all slowing down, and that's because the body is shutting down. And so these processes are also going to slow down, and the body is going to work on keeping just the essential things going, like the heart, the lungs, and of course the brain. So you may also start to notice some changes in skin color as a person is becoming pre-transitional. You might start noticing that they're more pale, that they have less elasticity to their skin. We call that poor skin turgor, and that's where you might see some tenting. You know, normally when we pinch our flesh, it just springs back. It just springs back to where it's supposed to go. And when a person is becoming dehydrated, which is also a natural process of dying, their skin will tent and it will hold that shape when you pinch it up. And sometimes you will see a mottled discoloring start. And in the pre-transitional phases, sometimes these things will wax and wane. They'll come and go. You'll see You'll see mottling and you'll see changes in skin color, and then they'll have a good day and things will be good. So in those pre-transitional phases that could take days to weeks, sometimes it's only hours that we're seeing that body show those pre-transitional phase. So people will sometimes rally in the end stages of life where they have really good days and you think, oh, okay, well, everything's kind of back to baseline, but it's not. It's kind of a trick. The body will just have this last spurt of energy sometimes. It can last days. I've seen it last weeks, not commonly, but I have seen a person rally for weeks and then rapidly decline. When a person is going into the active phases of dying, they have stopped eating for several days usually. They have stopped drinking for several days. They should be getting daily visits by social workers and nursing and any other ancillary staff that can help out with those daily visits. But at a minimum, they should be getting daily visits from a social worker and a nurse. So those are the things that are going to be happening when a person stops eating and drinking. They're going to be put on daily visits. And the nurse is going to come and assess the patient daily for these signs of impending or imminent death. Those signs would be, again, those changes in color of skin, lack of responsiveness. Sometimes people begin to show some signs of discomfort or changes in breathing. They will have that raspy breathing sound or increased respiratory and oral secretions that you can hear. And it's not necessarily in the lungs that you're hearing those sounds, more like fluids just hanging out here. And the best way that I ever heard it described was by a nurse who said, it's like when you're trying to get that last little sip of fluid through a straw and it makes that noise, because that's kind of what it sounds like when a person is having those secretions that they're not clearing. You and I, when we're awake and alive and doing normal things, are clearing our secretions, our saliva throughout the day without even realizing it. It's involuntary. We just do it throughout the day. If our mouth starts filling up with saliva or we have excessive spit, we will swallow and clear that spit. Or, you know, sometimes people have phlegm or mucus and they will spit it out. But when you get to that point where you're not responsive and you're unable to communicate, you also are unable to clear those secretions. And often people will want a suction machine. And so what a suction machine is beneficial for in home hospice is to clear those oral secretions that are hanging out in the mouth. Because that will be like a lot of drooling is what you'll see, is an excessive amount of drooling. And sometimes that can happen pre-transitionally too, where a person will start salivating and having an excessive amount of saliva, or we call it sialorrhea. You'll notice that pre-transitionally or even leading up to those pre-transitional phases in a person that has dysphagia. This is like difficulty swallowing. So those people are already having difficulty clearing their secretions, and you can hear that sound sometimes too if they are not swallowing appropriately and they can't clear those secretions. It sounds like this. I just like to demonstrate that for people because once you hear it, you never forget it. A lot of people call that the death rattle, and really it's just where those secretions are hanging out, and it's usually pretty painless for the patient. They typically are not uncomfortable with those things. What I usually advise is to reposition the patient turn them on their side. Make sure that their neck is not hyperextended, because that makes a horrible sound too. You just want to make sure that the patient's comfortable, that their neck and head are supported, and that they're in a position where those fluids can drain out naturally. But again, the suction machine, you're not going to be able to get deep enough down to clear what you think you're hearing. And really, a suction machine is only good in those last phases or active dying, with like a yonker, where we call it a yonker. I know there's some debate on the pronunciation of this, but you're going to clear the mouth out with that hard suction, and that's just going to decrease those sounds. Other things that we use are medications like glycopyrrolate, hyoscyamine, which is Levsin, and glycopyrrolate is Robenal. We use the scopolamine patch that goes behind the ear. That will help dry up those secretions. Now, if a person's alert and oriented, you want to be careful what medicines you're using to dry up those secretions. Those anticholinergics are going to be drying, and they can cause some neurological side effects. You know, a person can be dizzy or have a higher fall risk if you're giving those medications when they're more alert. But at end of life, the scopolamine patch is pretty good at drying those secretions. I think Robenal is probably, the glycopyrrolate is probably more appropriate when a person is up and at 'em, unless you're in the hospital and they can give it IV. Because I know in the hospital, when a person is GIP, for example, at end of life, they will get Robenal or glycopyrrolate via IV route, and that works pretty good. Hyoscyamine dissolves under the tongue. It's sublingual. And most of the medicines that we use in hospice are designed to not need to be swallowed at end of life. So there is a Robenal or glycopyrrolate that dissolves under the tongue, and that scopolamine patch stays on for 72 hours. That's also something that you see when you have motion sickness, in case you wondered. Those patches are what they use when you have motion sickness, or you're going in an airplane or a long car ride. So that is your scopolamine patch. Maybe I'm pronouncing these wrong, but I've been a nurse for over 25 years. So my pronunciation is it's going to stay wrong probably, unless someone would be happy enough to correct me. I'm happy to take direction. Some of the other meds that we're going to use at end of life, when people start having shortness of breath, that's where your morphines and your opiates are going to come in. We do use hydromorphone in patients that are allergic to morphine at end of life. So typically what we are using is going to be morphine or a liquid oxycodone or liquid Dilaudid, which is your hydromorphone. Those are the medicines we use at end of life. Opiates do help decrease respiratory effort. I will say that the doses that we use are fast acting and they're short acting, and they stay in the system a short amount of time. So when you're up and about, those medications are good for breakthrough pain, but they're going to be less helpful when you have chronic long-term pain, whereas at end of life, you may need medications every 30 minutes to an hour, and you can't take those medications and swallow them. So that's where our liquid medications do come in handy. So at end of life, you could see changes in breathing, where a person is having really hard respirations, where they're really just using their whole body to breathe, and you will see that whole body effort, and it just really seems like they're working really hard to breathe. So that morphine and those opiates are going to help decrease that respiratory effort that happens at end of life. And I promise you that giving those medications isn't going to be, a lot of people feel if they give those medication that they're hastening death, but that's not the case. I had a nurse practitioner tell me when I was young in my nursing journey, maybe I had some ideas about not giving opiates. I felt like maybe we were hastening death. When I was in my 30s and late 20s, early 30s, I used to feel like maybe I was hastening death by giving those medications. But a nurse practitioner told me when I was in my late 30s, early 40s, she said, Stacy, You are not causing the person who is dying to die. You're not making it happen any faster. But if you withhold these medications, then you're making them have an uncomfortable death. And the thing about managing symptoms at end of life is that you want to manage those symptoms as soon as you see the clue that those symptoms are there. Because if you wait until a symptom is severe, now you're chasing the symptom with the medication, and it's more difficult to control someone's pain or shortness of breath when you're chasing it at its peak, when it's so strong and so hard. It's often hard to bring it back down, but if you stay on top of it and you stay consistent, then you can maintain that comfort for the patient. And the dosing that we use is pretty light generally. I would say standardly, I don't see people need more than 5 or 10 milligrams of morphine throughout their dying process standardly. Now, I've seen people who, no matter how much medication you give them, they're not going to get comfortable, and they're going to need that GIP or inpatient hospice experience to bring their symptoms under control. Because sometimes they need that 24-hour nursing and that IV medication or subcutaneous medication delivered, so that they can be comfortable and have that death that they desire to have, which is pain-free. The biggest thing that patients say to me when they're alert before they reach that end phase, that active phase of dying, is that they don't want to have pain. They don't want to be in pain. That's what they tell me. I don't want to be in pain. My biggest fear is that I will be in pain. Please don't let me be in pain. And a lot of times caregivers and family members are very hesitant when we start using the word morphine. And anyone feels hesitant when you start throwing around the heavy hitters and the opiates, right? Because we have heard so much in the news about people who have used it as it's not intended. And that can be frightening. It can be frightening to hear those names that you've associated with negative things to do the things that you need to do to manage symptoms for your family or your loved one. So education is key, and when you have a person on hospice, before they get to this active phase, it's just really good to review this at every visit. What would you do if a person had shortness of breath? How much do you give? How do you administer this medication? And hospices have 24-hour triage lines so that all the things that you've said to your patients and their families, sometimes they forget it when it comes down to the time, and they need to be walked through it again and again and again, because you start to question yourself when you're dealing with the death of your loved one or managing those symptoms. You ask yourself, am I doing the right things? Am I doing it right? Is this what the nurse said for me to do? So as a nurse, I would say make sure that you're educating at every visit how to manage those end-of-life symptoms, what they look like, how they can differ for each patient. Some patients, they're fine one day and they go to sleep and never wake up the next day. And that's what I hope for myself. But some patients really have a lot of symptoms depending on what their disease process is. You know, cancer patients have pain. Patients who have a diagnosis of some type of cancer that's metastasized, and depending on what the cancer is, they really have sometimes a lot of nausea and a lot of pain, and it's sometimes very difficult to get that pain under control. Patients who have respiratory symptoms, chronic obstructive pulmonary disease, your oxygen users, your people with cardiac diseases that need oxygen. Those patients really have a lot of shortness of breath, and it's frightening when you can't breathe. I have had so many patients at end of life, before they get to that stage where they are, calm, they are very restless. And they tell you, I can't breathe, I can't breathe. Another symptom that you will see when a person is getting toward that active phase of dying is restlessness, terminal restlessness. The person just can't get comfortable. It's like they've got ants in their pants and they just can't sit still. And sometimes families will just have a horrendous night. They will just have a horrendous couple of nights trying to get that under control because the patient is soon going to pass, and now they're imminent. They want to drink a water. They want to sit up on the side of the bed. They can't breathe. They need you to turn up the oxygen. They don't want the oxygen on. They want to sit up on the side of the bed. They need to go to the bathroom. And this is happening, sometimes every 15 minutes, sometimes every 5 minutes. People get really anxious when their body is starting to shut down sometimes. Maybe they don't realize what's happening, but they're nervous about it. They sense that something is off, something is happening. And some patients are very peaceful with the fact that their end of life is coming. I've had patients say to me, I've said to them, I'll see you tomorrow, and they'll say, I won't be here tomorrow, and they're not. Some patients really know and they're at peace with it. Some patients never are ready to go and they're not at peace with the death and dying process. But they do want to be comfortable. They do know that they're going to die, and they are accepting of that management of those symptoms. It's just some people really fight until the very end. And that is the hardest thing to watch sometimes as a nurse, when you can't get someone comfortable. And that's where your inpatient or your continuous care come in, which is a conversation for a different day. But active phase of dying, we say actively dying when a person is imminent, when we expect that they're going to die at any time. That is changes in skin color, no eating and drinking for several days, changes in level of consciousness, changes in breathing, and changes in anxiety. Those are the things that we're looking at when we say active dying. I mentioned it in a separate video that really had nothing to do with the types of patients that I see on a routine basis. I have worked in GIP settings. I have done admissions of patients who are intubated and need to be extubated and are in those GIP settings. I have managed with the doctor, those symptoms for those patients. And when I talked about actively dying in my other video, I was referring to my brother who had recently died and was on life support. But that question, when the person said, why are you calling it actively dying? I just wanted to clarify that there are phases of dying. When a person is at end of life, their disease process is shutting things down. It is killing those functions that are normal for us, that we take for granted every day. It is affecting the breathing, the way the heart functions, the way the liver functions, the way the kidneys function. And those things are shutting down. The heart is one of those tricky things because it can just happen anytime. Any death and dying process can happen at any time. So when a person comes on hospice, I think it's important to prepare them for the likelihood that a person could go at any time from the time that they stop aggressive treatment. They could go at any time. But it's really important that we're vigilant as nurses and sharing what those symptoms could look like, and that we are providing comfort measures during those times. And how have you handled those active phases of dying? How do you feel about administering those comfort meds? Is that an ethical thing for you, a religious thing for you? Some of us are very devout in our religious beliefs and feel against giving those types of medications. So I guess being a nurse can put you in strange situations. But I would love to talk about those things in the comments. I would love to make more videos answering more questions. And if you have any questions or comments, then I ask that you leave them in the comments for me, and like, subscribe, and follow for more. I thank you so much for watching, and I hope to see you soon. Bye-bye.